Assalamu alaikum. Today I'll be presenting the urinary incontinence in women, the anatomy and the pathophysiology. Starting with the anatomy of the urinary bladder anatomy, the bladder lies immediately behind the pubic bones. The bladder is basically pyramidal in shape when contracted. Bladder when distends becomes ovoid and extends above the pubic bone. The capacity of average adult bladder is about 500 ml, and it's voiding up to 7 times per day is normal in waking hours. The volume of each void being 250 to 300 ml, which can be more in the morning void. The urinary bladder anatomy is basically consists of apex and base. The apex is being directed anteriorly, and the base is directed posteriorly. Other than that, it has a superior surface and 2 inferior lateral surfaces. The base of the bladder is a trigonal area, which is known as trigone. The ureters open on 2 superior surfaces of the trigone, and the inferior area of the trigone is continuous with the bladder neck. The bladder neck is in continuity with the neck with the urethra, which in females is about 2.5 to 4 centimeters long. The urethra is basically being supported by 2 forms of sphincters. The internal sphincter is formed by the rings of smooth muscles at the bladder neck, whereas the external sphincters is formed by the muscles of the pelvic floor. Both sphincters help to close off the urethra and maintain the continence. Bladder histology is also important in distension of the bladder. The mucosa consists of urothelium, which is transitional epithelium. It consists of flat umbrella-shaped cells which can expand and allow the stretching of the bladder. Other than that, it has submucosa. The muscularis layer composed of detrusor muscle. The detrusor muscle can stretch up to 4 times without increasing the linear tension. And then adventitia. Bladder function. The bladder, urethra, and urinary sphincters work in concert to store urine at low pressure and to void voluntarily at socially convenient or appropriate times. The detrusor muscle and the internal urethral sphincter are predominantly smooth muscles, that is involuntary, and the external urethral sphincter and the pelvic floor muscles are predominantly striated muscles, that is under voluntary control. The neurological control of bladder basically comes from sympathetic, parasympathetic, as well as somatic nervous system. The pelvic nerves is the parasympathetic system, which basically has muscarinic receptors, mostly located on the detrusor muscle, which controls the contractions during voiding phase. On the other hand, the sympathetic nervous system, which is basically by the way of hypogastric nerves, have 2 top receptors. The one on the detrusor muscle is negative, and beta receptors which inhibit the contraction of detrusor muscle. On the other hand, we have alpha receptors, which are located on the neck of the bladder and would be basically responsible for the activation of the alpha receptors will be responsible for the tonically contraction of the neck that will be required for continence. The pudendal nerve is somatic supply, which basically be innervating the external sphincter, which will be responsible for the voluntary control of the bladder. The whole of the system is basically being controlled by pontine micturition centers, which switches between the filling and the storage and voiding phases. Urinary incontinence. The urinary incontinence is defined as the complaint of involuntary loss of urine or the leakage of the urine. The condition occurs in both sexes, but more common in women. The urinary incontinence symptoms are highly prevalent among women, with having a substantial effect on health-related quality of life and associated with considerable personal and social expenditure. Incontinence in men is a consequence of usually prostatic enlargement or for damage from continence mechanism during surgery or radiotherapy for prostatic cancer. By contrast, incontinence in women is typically related to the dysfunction of the bladder, pelvic floor muscles. Such dysfunction often arises during pregnancy, childbirth, or time of menopause. The range of reported prevalence of urinary incontinence of any subtype in adult women is about broad. That's about 5 to 72%, with studies usually converging to about 30%. This enormous variation is observed both within and between the countries. If true prevalence rate varies between the countries, it is obscured by the differences in the perception of the urinary incontinence and willingness to report the incontinence. The association of urinary incontinence with all ages is well characterized. Across all available studies, age-specific incidence is less than 2% per thousand persons in a year, less than 40 years of age, but increases with age. For the population as a whole, stress incontinence is more common than either urge or mixed incontinence in most cases. However, the prevalence of stress incontinence basically peaks at 5th decade, while thereafter the prevalence of mixed and urge incontinence continues to increase. Causes of incontinence in women. First of all, the reversible causes of the incontinence, which has a mnemonic of diapers. It includes delirium, any form of infection that be irritating the bladder, It includes atrophic vaginitis, which is basically during menopause, pharmaceutical agents, psychological, excessive urine output, restricted mobility, and stool impaction. The pharmacological causes of incontinence include many drugs, including ACE inhibitors, alpha-adrenergic agonist and antagonist, amlodipines, anticholinergic antihistamines, calcium channel blockers, diuretics, psychotropic agents, sedatives, hypnotics, and tricyclic antidepressants. The type of incontinence. There are two main types of urinary incontinence, including stress incontinence and urge incontinence. The stress incontinence is the complaint of urinary leakage on effort or exertion or in association with coughing or sneezing. The urge incontinence, on the other hand, is the urinary leakage associated with sudden compelling desire to void that's difficult to refer. On the other hand, mixed incontinence has the symptoms which is basically mixed nature of stress and urge incontinence. The other rarer form of this incontinence include postural incontinence, which is the loss of urine in the change of body position, maybe at standing up or bending over. The nocturnal enuresis, continuous incontinence, which commonly includes the vesical fistulae. Functional incontinence basically refers to incontinence in the setting of physical or cognitive impairment, such as fracture, dementia, that limits the mobility and ability to process the information about the fullness of bladder. Stress incontinence. The stress incontinence, by definition, is the complaint of urinary leakage on effort, maybe on exertion in association with coughing and sneezing. Most common form of incontinence for men, accounting about 50% of the total cases. In stress incontinence, the pressure of the bladder exceeds the urethral pressure, which leads to the incontinence without the active bladder contraction. To understand the stress incontinence, the common causes of stress incontinence basically include the most common cause is pregnancy or the normal vaginal delivery, but can be because of menopause, the pelvic surgery, pelvic organ prolapse, hysterectomy, chronic cough, internal sphincter weakness, or obesity. The types of stress incontinence basically includes the genuine stress incontinence and intrinsic sphincter deficiency. Genuine stress incontinence is described as hypermobility of the bladder outlet because of the poor pelvic support and an outlet that was competent at rest but becomes incompetent only in the position of increased intra-abdominal pressure. It creates urethral hypermobility that results from the loss of the support to the bladder neck and urethra, such as during movement of the peak of the abdominal pressure, the urethra loses its support. To understand this condition, we have a HAMMOCK hypothesis that actually states the bladder is supported by a specific form of the endopelvic fascia, which is basically known as the pubocervical fascia. The pubic cervical fascia basically extends from the vagina, the cervix of the vagina, to anteriorly to the pubic symphysis. Now this fascia, along with the levator ani, which supports it laterally, it supports the bladder neck and the urethra. Now these structures functions as a hammock that results in compression of the urethra with increased intra-abdominal pressure, preventing any urinary leakage. To demonstrate it pictorially, now this is the pubis which extends anteriorly. Posteriorly we have uterus. In between them there is a hammock that is formed by the pubocervical fascia. The bladder, which rests on the surface of this fascia, is being supported by it, and the urethral neck is basically being supported and also contracted by this fascia during time of increased intra-abdominal pressure. The endopelvic fascia, which urethra is compressed during rest and activity. The compression combined with intrinsic urethral sphincter compression effectively closes the urethral lumen and prevents the involuntary loss of the urine even when the intravesical pressure increases. The loss of the support results in hypermobility of the urethra, such that rather being compressed at the time of increased intra-abdominal pressure, the urethra moves downwards because without being compressed, resulting in lower pressure in urethra and then in bladder, with the consequent loss of urine. The other mechanism includes the intrinsic sphincter deficiency. If the urinary sphincter mechanism is damaged, a specific form of stress incontinence occurs, which sometimes referred to as intrinsic sphincter deficiency. The weakness of the urinary sphincters result from trauma, repeated urogynecological surgeries, neurological diseases, aging, or diseases leading to the systemic muscular atrophy. The urge incontinence. The urge incontinence is defined as a complaint of urinary leakage that is associated with sudden compelling desire to void that is difficult to defer. Unlike the physical changes associated with stress incontinence, the urge incontinence involves the physiological disturbance to the bladder function. There are three main causes of the urge incontinence being hypothesized. That is Detrusor overactivity, poor detrusor compliance, or the bladder hypersensitivity. Detrusor overactivity, many patients with the urge incontinence have measurable spontaneous uninhibited contraction of the detrusor muscle during bladder filling. This is called detrusor overactivity. Detrusor contracts during form of emptying but not during filling. So in causes where the detrusor contracts during filling, you have detrusor overactivity. These contractions can coincide with perceived urinary urgency and urge incontinence, and can result if the pressure generated overcomes the resistance in the resistance of the urinary sphincter. Early hypothesis of this detrusor overactivity were anatomically centered of the spine or maybe parasympathetic nervous system dysfunction, which was called the neurogenic hypothesis. Detrusor overactivity does occur in spinal injury, substantial spinal diseases, multiple sclerosis, but now its general population of the neurogenic causes of the detrusor overactivity are uncommonly identified. The detrusor overactivity, which mostly occur now, is idiopathic without finding a single pathophysiological cause. Poor detrusor compliance comprises of, in low compliance, the bladder fails to stretch, which causes increased pressure and discomfort during filling and limited capacity. This pattern is basically typical after pelvic radiotherapy or can result from prolonged periods of catheterization. The bladder hypersensitivity refers to the urothelium that is not urothelium function, urothelium which is not just a barrier but also responsive structure that able to detect the thermal, mechanical, chemical stimuli. So whenever the urothelium is any form of augmented, or urothelium is basically any form of stimulation occurs, either through it augments the detrusor muscle, either by the neurotransmitters or through own spontaneous electrical activity. With the recognition of the urothelium as a pivotal mediator of the bladder function, much attention has been concentrated on the role of the urothelial inflammation and infection in the etiology of overactive bladder syndrome. Thank you.
अच्छा सर, मंजू साहब, ये हमारी 2 लेक्चर्स हैं इनकॉन्टिनेंस पे. सो आज जो था वो थोड़ी सी बैकग्राउंड डिस्कशन था, और ताकि इसका थीम सेट हो जाए. नेक्स्ट वीक इनकॉन्टिनेंस का जो ट्रीटमेंट है और जो उसकी मैनेजमेंट है उस पर डिस्कस करेंगे. बेसिकली इट्स अ कॉमन denominator in not only in males but also in females. And to my understanding, if you stand in a clinic like we have, filter clinic, almost 10% of people, they do come with these kind of complaints. And actually these are, if we talk about women, these are the women who come at the very late end of the clinic because of a lot of problems. So it's not only a disease or a disease complex, but also it's a social problem. The kind of society that we have, we don't have females who come to us on their own. It's the compulsion of a lot of people who just put these women under a lot of stress. So if you imagine, these are the people who are actually outcast of their homes. They are there not in the mainstream or the nucleus of a house. So it's a very difficult problem, and they won't come up unless and until they feel that you have got some confidence with them. Otherwise they won't confide in you those kind of details which lead to this kind of complex problem. Madhu sir?
इसमें जो है ना वो, I think it was a good presentation, but it was too rapid and slides were too busy. So I think next time we should make, for example, this only you should have a diagram and then you should be able to describe it so that you remember the things. So next time I think we should make 3-4 lines ज़्यादा नहीं होना चाहिए, like 2 busy slides now. It should be not too much rapid presentation so that others can understand. एक तो ये थी चीज़, और दूसरी चीज़ ये है कि genuine stress incontinence जैसे आपने कहा था ना, तो it's not used in the ICS definition nowadays. GSI या genuine stress incontinence has been replaced by urodynamic stress incontinence, the terminology. ठीक है ना. तो ये है, एक तो ये थी. दूसरी जो है वो चीज़ अगर समराइज करें हम तो 50% केसेस में SUI है, स्ट्रेस यूरिनरी इनकॉन्टिनेंस है, और बाकी 50% में जेन्युइन स्ट्रेस वो अर्ज इनकॉन्टिनेंस एंड मिक्स्ड है. तो द कॉमनेस्ट प्रॉब्लम इज स्ट्रेस इनकॉन्टिनेंस. उसमें दो इम्पोर्टेंट टाइप्स हैं. एक है यूरेथ्रल हाइपरमोबिलिटी एंड ISD. यूरेथ्रल हाइपरमोबिलिटी एंड ISD. तो यूरेथ्रल हाइपरमोबिलिटी का जो कॉज है या पैथोफिजियोलॉजी है, तो जैसे डॉक्टर साहब ने बताया है कि हैमॉक इफेक्ट है, हैमॉक हाइपोथेसिस. हैमॉक हाइपोथेसिस में ये है कि दी एंडोपेलिक fascia गेट्स वीकेंड आफ्टर मल्टीपल pregnancies and labor and damage to the genital tract. And if there is a weakness in the endopelvic fascia because of multiple pregnancies, this is the commonest cause here in Pakistan. This endopelvic fascia damage and multiple pregnancies and labor, especially vaginal deliveries. So that's the HAMMOCK effect. And then the ISD is the intrinsic sphincter deficiency because of previous gynecologic surgeries, and estrogen deficiency or atrophy of the muscles, especially in the old age people where there is a estrogen deficiency. So one of the treatment for those patients is to have a estrogen therapy. The idea of doing this, the division into two, this, for example, the HAMMOCK hypothesis or urethral hypermobility and ISD is that the treatment of these two is different. For example, we will discuss in future, but for example, in urethral hypermobility we have a sealing operations, mid-urethral sealing, and for the ISD is the sphincter deficiency or injection therapy. So this is what, and there are some tests to differentiate these two things. फिजिकल एग्जामिनेशन जो है हम नेक्स्ट टाइम करेंगे.
Yes, sir. Physical examination tests.
ओके. तो अर्जेंसी इनकॉन्टिनेंस जो है उसमें 3 मैकेनिज्म्स हैं जो डिस्क्राइब हैं. एक तो जो है वो डिट्रूसर ओवर एक्टिविटी है सर, ठीक है. डिट्रूसर ओवर एक्टिविटी इज द इनवॉलंटरी डिट्रूसर कॉन्ट्रैक्शंस ड्यूरिंग द फिलिंग फेज ऑफ सिस्टोमेट्री. तो वो एक फैक्टर है. दूसरा जो है वो पुअर कंप्लायंस है और इम्पेयर्ड कंप्लायंस. और तीसरा जो है वो यूरोथेलियल हाइपर सेंसिटिविटी है. और यूरोथेलियल हाइपर सेंसिटिविटी जो है या ब्लैडर हाइपर सेंसिटिविटी का जो मेन कॉज है वो है इन्फेक्शंस, UTIs एंड वैजाइनल कंटामिनेशन, स्पेशली द जेनिटल इन्फेक्शन इज द मेन कॉज ऑफ ब्लैडर हाइपर सेंसिटिविटी. तो ये तीन है. बाकी जो मिक्स्ड है उसमें जो है वो आपको दोनों चीज़ें मिलती हैं और ट्रीटमेंट इज़ डिफरेंट इन द मिक्स्ड. लेकिन बिफोर वी गो फॉर एनी लेबलिंग और एनी इन्वेसिव ट्रीटमेंट, द यूरोडायनामिक टेस्ट इज़ वेरी इंपॉर्टेंट एंड अदर कॉजेज ऑफ incontinence, like she was telling us about the functional incontinence and postural incontinence and other things must be excluded before we start any treatment, because for those functional and, for example, postural, the treatment will be more focused to the cause, not to the this SUI and
right. So sir, you have rightly pointed out that this low estrogen is actually the key point, and particularly this problem as well as the problem of retention of urine or difficulty in urination in women is most probably or most commonly appearing in post-menopausal period, and this is the period when the estrogen is low. Estrogen can be low in early period also, early age group, but it is mostly after 45, around 45. What it does, to my understanding, is it causes not only dry vagina as well as dry urethra. So there is no such thing as stricture in that case, but most probably it is the dry urethra which leads to urinary retention in a female. And we do have a lot of these female who are put on alpha blockers. So what they need is actually replacement of estrogen rather than alpha blockers or dilatation of urethra. If there is no history of trauma and there is no history of any intervention, surgical intervention earlier, there is no cause for a 4 centimeter urethra in a female to get blocked by stricture.
Yes, female में जो है stricture is extremely uncommon. The anatomical stricture. लेकिन ये जैसे estrogen deficiency old age में must be kept in mind, and dilatation helps in these patients somehow.
Right. So the second point is, as we have got this theme of putting everything that we discuss into our common practice, I think this is a way forward for the clinic, which is a functional urology clinic. They should have a lot of these problems with them. Obviously they are seeing them, but everything should be put in perspective so that it can be sort of a delivery of a service for the problems that we have in our hand, rather than doing something which is extraordinary, and that is a replacement of bladder with a new bladder and things like that. So what I am actually stressing on is the men's health as well as the female health. This is very important, urology health, and this is a new concept. It's a part of office urology. You can do a lot of things, for instance physiotherapy, for instance relaxing exercises. So all these things lead to a very important implication in terms of voiding, proper voiding, without any obstruction, without any leakage. So if you have got these two endpoints, leakage and obstruction, you can place your patient within these two endpoints. So this is the new way of thinking and dealing with such kind of patients. And mind you, these are a lot of patients, and there are not many people who can help them out in our country. So I think this group, or the group that is working in urology in our setup, has got the biggest number of these cases, and this is a neglected sort of a population.
जैसे Detrusor overactivity should be differentiated from the overactive bladder, ठीक है ना? तो उसको कैसे differentiate करेंगे आप? How will you define? Can we define overactive bladder? Like, this is important concept especially in urgency incontinence. So I think we should have included the definition of overactive bladder and its causes in this pathophysiology.
इसलिए sir that is the angle of urodynamics. If you see through that lens, the whole thing changes. But if you see through the lens of symptomatology, everything is different. So जैसे आपने कहा ना कि if the background is classifying all the diseases in terms of urodynamics, then there is another classification that is more pertinent to.
Can we ask Dr. Mavish to explain what's overactive bladder, just to.
So overactive bladder syndrome is basically a condition which you have urge, and along with nocturia with or without urge incontinence. It's a condition in which urgency is present, but urge incontinence can be present or cannot be present. It's not synonymous to urge incontinence, but it includes urge incontinence.
So, anybody to improve the definition of overactive bladder? What is overactive bladder? Because this is very important for the urgency incontinence definition.
There is one definition: frequency, urgency, and nocturia. This child is called
Without urgent.
And it is dry and wet.
Without any.
Wet when there is incontinence, and dry when there is frequency, urgency, and nocturia.
Anybody else?
Yes,
Huh?
findings, sir. Detrusor overactivity is the urodynamic findings. You can't label on the basis of symptoms. You labeled as a case of overactive bladder after urodynamic study, sir.
Anybody else?
Even poor compliance is a urodynamic bladder. And bladder high sensitivity, none of the three is a clinical diagnosis.
Hypersensitivity you cannot say. You can only say that this patient has got urgency. But whether it is due to hypersensitivity or compliance or overactivity, only urodynamics test is going to tell you. And I don't know what is for bladder hypersensitivity. You cannot diagnose on urodynamics bladder hypersensitivity. What is the diagnostic tool to specify hypersensitivity? I've never read.
You see, the basic principle behind urodynamics is you got to have a question in your mind, and the questions arise whenever there is some gray area, there is some doubt, there is no clarification. So whenever there is something which you have explained, a symptom complex, urgency, frequency, nocturia. Now this is the trilogy. Now this trilogy is actually compelling you to go towards a urodynamic suit, put the patient on urodynamics and get some thing out of it in terms of pressure flow study. Now on pressure flow study, Manzusa will bear me out, it's only then you can label this patient as having overactive bladder, because you are seeing this patient not under anesthesia but in real time how the bladder is behaving in terms of dealing with a lot of volume which is coming into the bladder and how the bladder is evacuating itself. So it's a combination of storage and evacuation of the bladder.
The overactive bladder is defined as it's a symptom complex, okay?
Pre-symptom complex.
And urgency is the important component of that definition. Associated with urgency, with or without frequency and nocturia. Okay? So urgency is important definition of, but with or without, associated with or without frequency and nocturia. What is frequency? How will you define frequency of urine?
Number of episodes of micturition more than 7.
More than 7 times in the day. Okay?
Number of episodes is
Frequency.
Yeah. It's more
This
than
is
7
called
times in a day is a frequency level. And what's nocturia?
More than 2 times.
More than 2 times in the night. Wake up for urination for more than 2 times. और कुछ लोग कहते हैं more than 1 time.
More than 2.
तो ये भी important चीज़ें हैं इसमें करने के लिए. और जो poor detrusor compliance जो है ना, इसमें पाकिस्तान में जो कॉमन कॉज है वो रेडिएशन के बाद ट्यूबरकुलोसिस ऑफ ब्लैडर है. ठीक है? तो whenever you feel impaired compliance is a urodynamic disorder where you feel normally bladder is a low pressure system during filling phase. There's a no rise in the pressure up to the 400 ml of urine comes into the blood. So it's a low pressure system during the film. But in this poor compliant bladder, what happens that during the filling phase there is a slight rise in the filling pressure, and it continues even if you stop the filling during the filling phase of urodynamics. So पाकिस्तान में जो है अगर impaired compliance है किसी को या rising है और detrusor overactivity जो है वो IDCs हैं during the filling phase. IDCs का मतलब है कि involuntary detrusor contractions which should not be in the normal detrusor. ठीक है? तो this is how we differentiate these two, detrusor overactivity and impaired compliance. तो अगर किसी को impaired compliance है या poor compliance है तो tuberculosis should be excluded. और अगर detrusor ये जैसे bladder hypersensitivity है, इसमें there's a lot of input from the vaginal contamination in the females, and in that case urine culture may be negative, but high vaginal swab may be of some help, or history, contact history, and if the symptoms are present in the male partner or not is also important to diagnose the bladder hypersensitivity.
Right. Thank you. We'll continue this thing next week also. Now, a little 5 minutes for Dr. Khalidul Khalik. Lights off करो. तुम्हारा एसी क्यों बंद है? काम नहीं कर रहा. सबके पसीने बह रहे हैं.
Good morning. As you all know that we are continuously trying to improve the teaching and training program at SIUT. So for many years we have developed a skill lab here, but recently we have scheduled a vascular anastomosis skill lab, particularly for training of the residents. And before embarking on a patient, one must know about the history, examination and investigations. So you can have these from guidelines from our clinics. So in our skill lab, we have many videos for radiocephalic, radiocephalic and brachiobasilic AVF, where you can have an idea how to make a fistula and how to dissect out the vein and artery and then have an anastomosis. We have all these instruments which you need to make an IVF, and we have a biological material, like we have a esophagus and the trachea from a chicken that are more similar to our artery or vein, that you can have a easy anastomosis, and you can see there whether you are doing a proper anastomosis or not. Yesterday I have also discussed with Professor Zaid Sufi. They told me that we can have grafts, PTFE grafts, which are expired or which are non-usable for a patient. We can have grafts there, and we can have anastomosis over the grafts. So this is a schedule that we have made for July 2019. Recently we have included all these residents which are currently working in our unit vascular department, and Dr. Mavish, Suhail, Usama, Mubin and Mashkoor. So this is 5 days a week, from Monday, Tuesday, Wednesday, Friday and Saturday, except the Thursday because of the busy clinic. So the timing of vascular lab is from 8 to 6 o'clock. But we have limited because of our duties and all these schedules. So Professor Zaid Sufi will be supervising these activity on Tuesday and the Friday, because he came 2 or 3 days. And on other days I will be supervising all these activity. So this is the program that we have recently established. Dr. Asad, please.
Yes, and the kind of thinking that we have is this training of dealing with the vessel and anastomosing it properly is not only required for a vascular surgeon or if you are doing a vascular access, but it is part and parcel of a urologist training. The reason being, for instance, now 40% of your workload is related to oncology. And when you deal with oncology, you're actually dealing with a tumor which has got some blood supply either coming in or going out. And if you injure a vessel, or if there is a thrombus in the IVC and you want to take it out doing thrombectomy, you can't just be expected to ask your vascular surgeon to come in and help you out. Obviously, if there is a complication, then, and if a complicated case is there, then you can always ask your colleague, but you have to do it properly in a way which is needed and required. So this is, to our understanding in this unit, part and parcel of a urologist training, how to handle a vessel properly and to do anastomosis. Whether you embark upon such a thing as a renal transplant in your later life, again as urologists, because urologists are the ones who are doing transplants, it depends upon your own skills as well as on your own feeling and your own liking. But as I have said earlier on, this has to be done properly, and the way to do properly is not to handle a human hand for the very first time, because if you do something for the very first time, there is a very high likelihood that it gets failed. Failing arteriovenous fistula on a human hand, I think, is too large an expenditure which is done not in a good way. So don't do it like this. First you put your hands over something which is like, as Khalik has said, a biological tissue which gives you the same feel as the feel of a human tissue, and then it's the needle handling, the tip of the needle, how it feels the tissue, what is the resistance that you have to overcome so that your fingers and your hand and your wrist should move accordingly. Now these are the choreographic movements that have to be learned by a surgeon. If you do it properly stepwise, then it will be a great asset to yourself and to your patient on whom you are actually working. So if you go by this, for instance, couple of weeks, maybe 2 weeks, Mavish was there, I think Nazish was there, and they would always give you the feedback whether it is helpful or not. To my understanding, I have made some fistula on those biological tissues myself. I got this article, got this idea from an Italian surgeon who happens to be an experimental surgeon, and he worked on different biological tissues. So this one was very close to the chicken model, is very close to the human model. So we can go over to the cadaver, we can go over to our animal lab, but this is kind of a prototype animal lab or animal working wet lab. So we go stepwise. Couple of weeks on these biological tissues, then if you get hold of all these instruments and the movements, you can move on to AV fistula, the distal fistula, and then the proximal fistula on the hand. And then you can progress with the graft placements and angioaxis. There are different techniques now with the vascular department of our unit, of our hospital. And then if you feel like, and your skills are those, then you can move on to transplant. So it's a stepwise transition from a novice to a transplant surgeon. You can be dropped out anywhere if you want to, or your supervisor says, for instance, Sufi Saab is actually has got this thinking that everybody is not for vascular surgery, everybody is not for transplant, everybody again is not for us for surgery. So we have to create skills. Nobody has got the skills from birth, but if you haven't got those reflexes, those skills, then you can do this practice time and again and it will come to you. तो इसमें ये नहीं सोचिएगा कि इसमें हम सेग्रीगेट कर रहे हैं किसी को, बहुत कोई स्मार्ट है, बहुत कोई स्मार्ट नहीं है. जो कमज़ोर होता है कभी कभी वो आगे भाग जाता है, आगे बढ़ जाता है, वजह उसकी होती है वो ज़्यादा मेहनत करता है. सो इसमें सिर्फ आपको ये पता लग जाएगा जब आप इसमें हाथ डालेंगे कि आपकी अपनी फील क्या है. दिस इज द बेसिकली इट्स फीडबैक बाय द टिश्यू टू योर सेल्फ एज अ सर्जन, एज एन ऑपरेटर. So this is the kind of world that we are actually living in. ये human rights का issue है. Don't do something directly on humans. Do something on animated site kind of a model, so that when you enter into the actual human face interface, then it will be less complication producing sort of application onto the side of the patient. So मकसद इसका ये है. And it's a good sort of activity, और आपको करेंगे तो मज़ा भी आएगा, इसलिए कि इंस्ट्रूमेंट्स वही हैं. असल में अगर तो इंस्ट्रूमेंट्स होते ना सेकंड क्वालिटी तो बात गलत हो जाती. अब यहाँ पे आपको फर्स्ट क्वालिटी हाई एंड इंस्ट्रूमेंट्स मिल रहे हैं जिसमें नीडल होल्डर से लेकर वो कैस्ट्रोवी जो है जो आप इस्तेमाल करते हैं. सो यू विल बी एक्चुअली हैंडलिंग दोज कैस्ट्रोवीजोज विच आर नॉट अवेलेबल टू योर compatriots in other parts of this city or in this country for urology training. This is something which is very new, and I have talked about this thing to my colleagues in Lahore and Islamabad. They are very much interested of coming here, spending some time so that they can be trained for fistula formation, other things.